Welcome, Facebook users, and thank you for joining us tonight for our TIF Talk. I'm Andrea Millers, and I'm with Endoscopic Solutions. We're very excited to have our special guest today. We have Dr. Seth Miller. Welcome, Dr. Miller, and thank you for being here today.
Hi, thanks for having me.
You're welcome. So Dr. Miller is a board-certified general and bariatric surgeon at Spectrum Health Lakeland and Lakeland General Surgery in Niles, Michigan. Prior to coming to Niles, Dr. Miller served as chief of bariatrics at I'm gonna mess this up. Landstuhl Hospital in Germany. How do you say it?
Landstuhl.
Landstuhl Hospital. There we go, in Germany, and also most recently is the chief of general surgery at Beaumont Army Medical Center in Elks. He's also a member of the United States Army, and he served as chief of surgery and a trauma surgeon while deployed in Afghanistan. So again, Dr. Miller's special interests include robotic surgery and minimally invasive procedures such as the TIF procedure for reflux. So again, Dr. Miller, thank you for being here with us this evening.
Yeah, it's a pleasure. I think it will be fun.
Fantastic. So we're going to go ahead and start. I know we usually start kind of explaining what is GERD and acid reflux, and you have a presentation for us, so you can go ahead and share your screen and kind of talk about it mechanically, and then go into a little bit of how the TIF procedure treats reflux. So we'll let you go ahead and share your screen.
Okay, well, thanks, Andrea. Hopefully that's working for us. So as you can see, I've done my homework and actually came with some slides for you. So hopefully that makes it a little easier to explain what exactly this TIF procedure is and what exactly GERD is. So GERD is gastroesophageal reflux disease. It's actually a very common disease. It affects about 1 in 5 Americans, or about 20% of the population. So basically, when we talk about GERD, what it is stomach acid that's supposed to be in the stomach refluxing up into the esophagus. And that can happen from time to time on a normal basis, but when that stomach acid starts causing symptoms or starts causing damage to the esophagus, that's when we call it gastroesophageal reflux disease. So the symptoms that you can get, probably the largest one is heartburn, and in severe cases, this kind of picture demonstrates that some patients can have pretty severe symptoms of heartburn. But the symptoms can be typical symptoms and atypical symptoms. So the most common symptom that we talk about is probably heartburn, that burning sensation in your upper abdomen or your chest where you have too much acid in your esophagus causing the symptoms, but also regurgitation where patients feel like stomach contents are coming up and they maybe have a sour taste in the back of their throat. Those are pretty common symptoms, along with bloating and difficulty sleeping, especially when they lay flat on their back at night. But then there's also some atypical symptoms, things like persistent cough, even sore throat. Sometimes patients can even develop asthma-like symptoms, or if they have acid reflux affecting their vocal cords, can develop hoarseness of their voice. Other kind of more unusual things, but that people might not necessarily think about are things like dental erosions. So it's not uncommon that a patient will be sent to me from their dentist because they had so much acid reflux in the back of their mouth that it affected the enamel of their teeth and started causing some decay. There can also be some ear and nose discomfort, and I've had some ear, nose, and throat surgeons actually send me patients because they were actually having reflux that were causing some of these symptoms in their ears and their nose. So reflux for a couple of different reasons, but the main concept is there's a mechanical problem between the interface between the esophagus and the stomach. So the esophagus travels through the chest and down below the diaphragm as it empties into the stomach, and that's where food goes from your mouth down and through your chest down to your stomach. Well, there's a couple of mechanical mechanisms by which the stomach keeps its contents down below the diaphragm. So as you can see with this slide, the movement of the esophagus propels food down to the stomach. And so some patients might have a problem with the esophagus propelling food down. There's a thickening of the muscle in the lower esophagus, which we call the lower esophageal sphincter. And that helps kind of tighten that junction between the esophagus and stomach that can help prevent reflux. But I think one of the things that this slide demonstrates is a lot of what reflux is caused by is due to pressure. And in this slide, what you see in that line in the middle is actually the diaphragm. And what you can see is that the stomach is actually protruding above the diaphragm, what we call a hiatal hernia. Now that's not normal, and because the abdomen is greater than the pressure in the lungs, which makes sense if you think about it. So when you take a deep breath in, the pressure in your lungs is less than the pressure in the atmosphere, and so air comes in. So that's going to have a lower pressure than in your abdomen. But when the stomach slides above that diaphragm, there's pressure pushing things up, and that can contribute to reflux. On the other hand, if your stomach is below the diaphragm, and if there's a portion of your esophagus below the diaphragm, that pressure inside your abdomen can help squeeze the esophagus shut and actually help prevent reflux. So having that condition of a hiatal hernia where the stomach slides above the diaphragm can create a pressure gradient that's kind of going in the wrong direction, so that stuff from the stomach is refluxing up instead of going down where it should be. Another thing that this kind of highlights is one of the things we frequently see as a cause of reflux is patients having increased weight and therefore increased pressure in their abdomen. So I'm a bariatric surgeon, and I do a lot of weight loss surgery, and that's in a way how I got into reflux surgery, because I see lots of patients that are obese and they develop problems with reflux, in large part because they have higher pressure in their abdomen pushing things up. So the treatments for reflux include medications, and these are listed in several groups. There's some medications which we call antacids, which neutralize stomach acid, and basically they act as a buffer to neutralize the acid. And then there's medications what we call H2 blockers. These are things like Zantac. Of course, now most people know Zantac has been taken off of the market, but this also includes Pepcid and different medications like that actually stop the production of acid from the stomach cells. Probably the most commonly known medications are what we call the PPIs, which stands for proton pump inhibitors. These are medications like Prilosec, which is omeprazole, or Nexium, and these actually stop the pumps on the cells of the stomach that pump out acid. And so these medications don't really stop the refluxing. What they stop is the production of acid. And so when we look at kind of on the whole, when you look at patients with mild symptoms, these are the patients that we would start with certain lifestyle changes. This would be things like avoiding certain foods that can cause reflux, like tomato-based foods, caffeine, alcohol. It would include eating smaller meals or not eating close to bedtime, or sleeping on an incline, and of course, weight loss. And then on the other end of the spectrum, for the severe GERD patients, that's when we tend to think about conventional surgery for reflux. Now, the reason that surgery is confined to those severe patients is because the conventional surgeries have inherent risk, but they also have some long-term potential side effects that kind of changes the risk-benefit ratio in favor of reserving those surgeries for patients with really severe reflux. Well, that kind of leaves a large between patients with kind of mild and moderate symptoms and those with severe, who can achieve some degree of benefit from the medications, but maybe have symptoms that are persistent despite medications, or for patients who simply want to get off the medications, it leaves a gap, and that gap is where more minimally invasive procedures like the TIF procedure comes into play. So the TIF procedure, TIF stands for transoral incisionless fundoplication. And basically what that means is the whole procedure is done by placing this device through the mouth So it requires no incisions, and it creates a wrap of the stomach around the esophagus, basically creating a valve that helps inhibit stomach contents from coming up into the esophagus. So the device is placed through the mouth into the stomach, and a wire is attached to a location where the esophagus meets the stomach, and the tissue is folded in and twisted, or we perform a fundoplication to recreate a valve that at the end looks something like this, where you have kind of a one-way flow where you have stomach contents staying in the stomach. And this kind of achieves a nice balance of symptom relief, but really ultimately what this looks like is this looks like what a person's stomach and esophagus look like normally in a patient that doesn't have a hiatal hernia and doesn't reflux.
Wonderful. Yeah, thank you, Dr. Miller. That was really great. It's nice to have the visuals to be able to explain everything. So we really, really appreciate that. One thing I did want to say that I forgot to say at the beginning of the event is that if you are watching and you have a question, please do not hesitate to ask your questions on the chat video at any time, and we'll do our best to have Dr. Miller answer the question as we continue to go on today. So anything else you wanted to add to that, Dr. Miller?
No, let's get to the questions.
Yeah. So we talked about GERD. You talked about how TIF works and how it helps treat GERD. I'm just going to go a little bit. What are there other options? I mean, you talked a little bit about PPIs and medical therapy. Are there other options for the treatment of GERD aside from the TIF procedure?
Sure. So the options, let's just discuss each individual option, kind of progressing from least invasive to most invasive. So we start with lifestyle modifications. So every patient that comes to me, I'll discuss lifestyle modifications. This includes weight loss and avoiding those foods. And so that's the starting place. And then medications are where we go in general next. And for a lot of patients, the medications control the symptoms, but as you mentioned, they don't really stop the underlying process. You're still refluxing. It's just you're not refluxing acid. So the TIF procedure is the next kind of line in that option that goes, which is a procedure that's done through the mouth. There's also a stretta procedure that's done through the mouth, which ablates. It uses radiofrequency ablation to kind of thicken the muscle of the lower esophageal sphincter. And then there's more surgical options, which include doing what's called a links procedure, which is basically putting in a string of magnets around the esophagus. And then there's the traditional surgery where you would do a complete wrap of the stomach around the esophagus. The other option, which is kind of a hybrid, which is actually probably the most common operation that I do, is where if a patient has a hiatal hernia that's contributing to the reflux, is I do a procedure where I laparoscopically, with the use of a robot, go in and fix a patient's hernia. So I bring the stomach down and I tighten up the muscles of the diaphragm, and that actually helps with an anti-reflux mechanism to keep the stomach contents in the stomach and keep them from going up into the esophagus. So I'll fix that hiatal hernia, but rather than do a conventional operation where I wrap the stomach around the esophagus, I then convert to a TIF procedure at the same time during the same anesthetic. And so it's a combined procedure where I'm fixing the hiatal hernia and then adding the TIF to create a nice valve as a barrier mechanism.
Perfect. That's a great explanation. Thank you. We do have a couple of questions that have come through, so I'm going to go ahead and ask some of those questions. From Derek, his question is, my PPIs are controlling my heartburn pretty well, but my regurgitation, sore throat, and hoarseness is still pretty bad. What's your advice? And then he comments as well. Also, my regurgitation is actually pieces of food.
Yeah, so that's a great question, and it highlights kind of exactly what we've been talking about. the medications decrease the acid production of the stomach, but they don't actually stop you from refluxing. So they'll control the symptoms of heartburn, but that does not mean that you're not still refluxing. And what that person described is that they're still regurgitating those stomach contents. And so my recommendation for that patient would be to be evaluated for something like a hiatal hernia, because there's clearly something wrong with a mechanism that normally provides a barrier between the esophagus and the stomach. And I would suspect that they have pretty significant regurgitation that would be seen on an evaluation of the patient. And I would suspect that they probably would have a hiatal hernia or some other problem with that mechanism that could be fixed surgically.
Right. Perfect. Thank you. So another question, this is from Beth. None of my PPIs are working anymore. Will the TIF procedure work for me since the meds don't work?
So that's a great question. And the answer is maybe. So, but this kind of highlights another kind of important thing to consider. The initial patient evaluation needs to be very thorough. And really what we want to do whenever we're doing a procedure is to clearly identify what the problem is. So for all my patients, I essentially get the same workup, which is tailored to what their background is. But for the most part, I get the same workup because I want to identify what exactly are the problems and how we should go about fixing them, and whether or not there's a contraindication to doing a procedure, because if we're going to do a procedure, we want it to work and we want it to be safe. So when I see a patient, I usually start with an upper GI, which is where they will drink some contrast, and I take a bunch of series of x-ray images. And that gives me kind of the lay of the land, where I'm looking at the esophagus and looking at the stomach. It will show a hiatal hernia if it's present. And if there's any other abnormalities, I might pick it up on that. But it gives me an initial kind of roadmap of what I'm dealing with. And then the next thing I do is an endoscopy. Okay. Included in that endoscopy, I'm looking at whether or not they have a hiatal hernia. I'm looking at how the valve between the stomach and the esophagus appears. And when I do that, I inflate the stomach with a lot of air to see, does it open up the valve? And that kind of simulates, if you had a full meal, what the valve might look like after a full meal. If there's any abnormalities of the lining of the esophagus, I'll take biopsies of that. And then I usually also combine that with what a test called the endoflip, where I blow up a water balloon in someone's esophagus, and I see the movement of the esophagus, and that gives me some idea of the function of the esophagus and whether or not that's reflux. But also, more importantly, in considering a TIF, it will tell me, is their esophagus working well enough that that if I put a valve mechanism in there, it'll be able to squeeze the food through that valve. And then the last thing I do is a Bravo study. Well, I'll put a capsule in the esophagus to measure the acid output in the esophagus over a period of time. So I get an idea of, are the patient's symptoms related to acid reflux? So when a patient comes in and asks, will a TIF help me? Kind of the answer is, well, we need to make sure we know exactly what's causing your symptoms. But for the vast majority of patients that have reflux and have a hiatal hernia, we need a repair of that mechanism. The TIF is a viable option to at least consider in the spectrum of options that we use to address reflux.
Perfect. I'm so glad you went through the diagnostic workup to determine whether or not a patient is a candidate for the TIF procedure, because that's generally a big question that a lot of these patients have. So thank you. He did respond and said he does have a sliding hiatal hernia. So it looks like he's been diagnosed with that already. So interesting. So let's kind of talk a little bit about what to expect the day of surgery, kind of what are the things that they need to do to prepare? What do they need to do to prepare for after and recovery? How long are they actually in the hospital? Are they overnight? Or do they do an overnight stay, or do they go out the same day? So maybe if you can kind of go into detail about that.
Sure. So the preparation for the surgery will vary a little bit based on patients, but it will include things like avoiding certain medications like aspirin or Plavix in some cases, medications that could cause bleeding. So even over-the-counter ibuprofen might be things that you want to avoid before the surgery. We do want to make sure that the stomach is completely empty during the time of the procedure. And so avoiding solid foods, like a large meal the night before, having like a liquid meal the night before, and certainly not eating the day of the procedure. So make sure your stomach is empty. That's included in part of the process. Typically, what I'll do with the patient before the procedure is I hand them a brochure that lets them know about the diet plan and what to expect after the procedure, so they can do their grocery shopping after the procedure. So that's something that's included in part of the preoperative evaluation. When they come in for the procedure, whether or not they're getting a hiatal hernia repair and a TIF or just a TIF, I do it in the operating room under general anesthesia. So they're completely asleep and have a breathing tube in for airway protection. Then we do the procedure. The hiatal hernia takes maybe an hour or less. The TIF itself takes around about a half hour or so. So in general, even a combined procedure is less than 2 hours, usually about an hour and a half. And for most, just about every patient, I keep them for an overnight stay in the hospital, usually home the next morning. A lot of that is maybe a bit of an overkill for some patients who come out of the procedure and feel just fine. But I do worry about things like having nausea or vomiting right afterwards. So I want to make sure that we can control that with medication. For patients that get the hiatal hernia, they might have a little bit more pain from incisions or from the insufflation of the gas. And so I want to make sure their pain's controlled. And so for those reasons, I like to keep patients overnight. Plus, they've just had a general anesthesia. And so in general, I'll keep them for an overnight stay home the next day. So afterwards, the big thing is the diet that you have to eat. Okay. And I think what's critically important to remember about this procedure is we're creating a flap, and that flap needs to heal. So the tissues of the esophagus and the stomach need to fuse. And that process takes about 6 to 8 weeks. And so, especially early on in the process, while that valve is healing, we really want to minimize any trauma to the area and let it heal nicely. And so, in general, we start with about a 2-week liquid diet. The first 3 days is actually just clear liquids, and we proceed from a liquid diet to a soft food diet, and eventually, after about 6 weeks or so, getting into more solid food. So it's this very steady progression. And so that's probably the biggest thing to know about the recovery. But what I will tell you is that the patients that I've had, as much as the diet progression can be a bit of a nuisance, and it means shopping for different things and not eating all the foods that you necessarily would want at first. In the long run, when they're sitting down to a dinner at a Mexican restaurant and they don't have reflux afterwards, they're glad that they waited and they had the valve work nicely for them, especially when they're off of their medications and just kind of enjoying their life. So it's worth it in the long run, but it's critically important to remember that in the short term, we want that valve to heal nicely so they get a good result.
Wonderful. So what about any physical activity? Are they able to go back to normal activity physically? We get lots of questions about that. Can I start exercising? Can I go back to work? All of those things.
Right. So physical activity is always kind of a tough one, because it'll be, can I go back to work? And the answer is, of course, it depends, right? Because it depends on what you do for work. Going back to a desk job where you're just kind of at a computer, that you can go back fairly rapidly, especially if you just get a TIF procedure, didn't have surgery, that you can go back to work fairly quickly. If you're doing any kind of mechanical labor and heavy lifting, those are things that we would postpone. We want you to have a full recovery, because again, if you're lifting something heavy and increasing that pressure, there's a chance that valve could be disrupted, and maybe you wouldn't get as good of a result. And so heavy lifting should be avoided for the first several weeks, and it should be a gradual progression. How much you can lift is somewhat dependent on kind of the size of the person. But in general, we start at very low weights. We start with very minimal activity and slowly progress and add it on. So there's guidelines that I hand out to my patients, and I tell them, this is a guideline, but it does get tailored to the patient's work, what they do to some degree. It gets tailored to their exercise habits as well. And so, but in general, the concept again is you want the valve to heal as well as possible, and the healing time is 6 to 8 weeks. But that doesn't mean that you have to be out for 6 to 8 weeks. But it certainly means that okay, if it takes 6 to 8 weeks, maybe by 2 weeks you can start gradually increasing, your activities, but not at the first few days. Okay.
Yeah. Yeah, that makes perfect sense. Thank you. We did have another comment. My husband has finally started taking his PPIs. How long should he be on these before considering an alternative like the TIF procedure?
So that's an interesting question. So in general, we think of the TIF procedure for patients that have been on chronic PPIs. So a year of being on PPIs would be kind of a standard answer. Having said that, though, we also consider it an indication if a patient doesn't want to be on PPIs. What's interesting, if you look at the labeling on a lot of these PPIs, they'll say use it for a 2-week period at a time. And so we use it kind of against that recommendation for patients that have chronic reflux issue, because in a lot of times this is a chronic issue, especially if they have a mechanism problem. So if a patient has a hiatal hernia, that hiatal hernia is not going to go away. Okay, it doesn't get better on its own. But in general, we say if you've been on PPIs for a year, that's an indication. But for patients that don't want to be on PPIs or have other reasons for not being on PPIs, that's something that we could even, without that criteria, I think could be considered for a procedure.
Thank you. Here's a kind of the elephant in the room. Is it safe basically to have the TIF procedure right now due to COVID, and what types of precautions are you at your practice or the hospital taking to make patients feel comfortable coming in to have either they're coming in for their workup or their diagnostic testings, or even coming in for their procedure?
Yeah, so I think that's kind of the question on the forefront of a lot of people's mind these days. So in terms of standard precautions that we're taking at my hospital, whenever a patient comes into our clinic, they get screened, they have hand sanitizers, and they wear a mask. Um, and and so that's standard. Any patient that's going to get a procedure actually gets tested for COVID-19 within a 72-hour window. And of course, we're using all the appropriate PPE, and all the staff members get screened every day as well. So in terms of the risk of getting COVID-19, I would suspect that coming to a hospital does not significantly increase your risk of getting COVID-19 compared to going to, say, any other, grocery store or somewhere else. We're taking the precautions that we can take. Having said that, if a patient is elderly and has lots of medical comorbidities, I mean, that's a consideration to keep in mind. But in general, for a patient that's otherwise healthy, with the precautions that we're taking in the hospital, I think we can say we're safely taking care of you. It is a pandemic. The virus is kind of everywhere. So that's just a reality that we have to live with. But there's few places taking as many precautions as a hospital is. And you're probably more likely to get the virus at home at a family gathering, which is what the data says. So if you're talking about being cautious, coming to the hospital is probably not a huge increase in your risk.
All right, perfect. Thank you. A couple more questions. Are there any swallowing difficulties with the TIF procedure?
So in terms of swallowing difficulties, immediately after the procedure, you might have a sore throat, and that can cause difficulty with swallowing. But if the question is, swallowing difficulties like foods getting stuck in your esophagus, the answer is actually not so much. So, and that's one of the big differences between the TIF and the old surgery that we used to do called the Nissen fundoplication. So the Nissen is where you wrap the stomach around the esophagus and you create a real tight valve. And up to maybe a quarter of patients have some difficulty with swallowing. Whereas the TIF, that tends to be a very rare occurrence. For the most part, patients just don't have that issue. Now, the caveat to that is, well, but you have to make sure that the patient had a complete and thorough evaluation before the procedure, because if they had some problem with the function of their esophagus beforehand, then you could have a swallowing problem. But that's why we do such a thorough workup beforehand to make sure there's no reason that we could see with the function of the esophagus why there would be swallowing problems. So if you're going to have a swallowing problem, we'd want to catch it before the procedure, and that's why we go through such a thorough workup.
Perfect. Thank you. So can you talk a little bit? I know you talked about recovery and post-op. Do you have any interesting patient stories or anything that, when you talk to patients every day about, options for treating GERD? Is there anything in particular that they always ask, or something that you want to make sure that you convey to people that are watching today?
Oh, there's probably several things. Well, I've had a few patients. Well, actually, I had one patient. Constantly what I'm kind of surprised about is the benefits of the TIF kind of improve the further you get out from surgery. And the longer you go without reflux, the better it gets. And so I had a patient who I did the TIF procedure on back in this, I guess it was last December. She came into the hospital for a different procedure and saw my nurse practitioner and like say, "Oh, make sure you tell Dr. Miller I love my TIF." and so it's something that's kind of interesting. It's like, well, patients will ask, "Well, how are you doing right after the surgery?" Like, well, I'm not sure yet. But when you see them 6 to 8 weeks out, they tend to get better. So I guess a recurring theme is I'll get patients that say, "I didn't realize it would keep getting better." So it got better pretty immediately. So you see some pretty immediate results, but there's also a lingering, for whatever reason, I think it's the lack of acid over a period of time, improves the results even further. And so I guess a surprising thing is that I've seen is that I'll have a lot of patients, once they're 8 weeks out or further, say, "Oh, I really love my TIF." Like, well, I told you a month ago you liked it back then, like, "Oh, but now I really love it." So that's
Well, probably because they're able to
a recurring theme that I've seen. So
probably because they're able to start eating after 8 weeks or further out, all the foods that they weren't able to eat before, right? That's probably what's
right. Yeah.
happening.
So early on, they just finished their liquid diet and soft food diet fatigue, and then once they can eat like a normal person and not have reflux and be off of their medication, then they're probably like, "Whoa, I love this now."
Exactly. That actually, a question just popped up. How soon after a successful procedure can I expect to be PPI free? So do you normally triage or titrate? Well, I don't know however you say it. Your PPIs.
Yeah, I normally wean patients off of the PPIs.
Okay.
And part of it's how the dose they start at and how long they've been on the PPIs. But in general, I kind of follow. I don't think there's a whole lot of science to it, but I kind of follow the 50% reduction over the course of each week. So if they're on Nexium 40 milligrams twice a day, I would probably go to 20 milligrams twice a day, and then 20 once a day, and then some people go every other day. But over that course of each week, kind of going 50% lower, because there can be a phenomenon where if you just stop the PPIs right away, your stomach can produce more acid. You get kind of a hypersecretion of acid. So by weaning it down slowly, you kind of avoid that, and that's usually the preferred approach, as opposed to having a patient all of a sudden have reflux again and worried about it just because they're producing more acid. So I tend to wean them off, but typically by that 6 to 8 week period when they should be all healed, that's when I usually have them completely off of PPIs. And I get, for every patient encounter, I get GERD quality of life scores, because I want to see the progression of where they were before and where they are afterwards. And so what I want to see on that last one is I have no symptoms, I'm super happy, and I'm off PPIs. So that's always where I check that.
Fantastic. One last question. Can you have a TIF, or can you get a TIF if you've previously had another anti-reflux surgery and your reflux has returned?
So that's a little bit of a tricky question. It kind of depends on what surgery that you had. If you have had a TIF, and it's come undone or was disrupted. If you had a steak dinner too early in the initial post-op period, for instance, you can get a TIF redone. So just kind of a touch-up job on that. And if you've had a TIF and you're still having reflux, so any procedure that we do to fix a problem could eventually wear down over time. It's like getting a knee replacement. You don't expect it to necessarily work forever. So over 10 years, 20 years, how long a period of time, that repair could break down. And the nice thing about the TIF is that if you have that occur, all the other surgical anti-reflux options are still on the table. So those would still be possible treatments that could be available to you. If you've had another anti-reflux surgery, it really kind of depends on what you've had, and in some degree to the way you've had it, whether it was open procedure or minimally invasive and laparoscopic. So a couple of weeks ago, I did a revised a patient who had a Nissen fundoplication in the past. Mm-hmm. And preoperatively, I counseled this patient that, well, with the scar tissue that you've had, this could increase your risk for having complications. But actually, when we got in there, her scar tissue was fairly minimal, and I think mostly because she had a minimally invasive approach. Mm-hmm. So the answer is it's possible to have a TIF after those procedures, but there's lots of caveats, and if you've had like an open Nissen fundoplication, which would have been very remote, there could be substantial scar tissue, and in that case, the risk might exceed the potential benefit. So it really just kind of depends on what you've had in the past, and so that's kind of an individualized decision that gets made.
Perfect, thank you. Well, let's see. Oh, one more question. Does reflux cause irritation on the back of your tongue?
I've had a lot of patients describe back of their throat or like a weird taste in their tongue. Mm. So it certainly can, and especially if it's like that sour, what we call water brash type of sensation, that can certainly be the case.
Okay. Well, that's all the questions that we have for tonight. We did get one question asking where can they find a physician in their area, so I can answer that question for the viewers. If you get on gerdhelp.com, which is our website, there's a lot of information about GERD and treatment options, obviously the TIF procedure. But in addition to that, there is a physician finder. If you're not in the Michigan area, you can put in your state and zip code and you'll be able to find a TIF trained physician near you. So you're welcome to visit gerdhelp.com. You can also get more information on our Facebook and Instagram page. And then we also have our YouTube channel. Just search GERD Help and you'll be able to watch any and all of our TIF talks that we've had in the past with our physicians and also patient testimonials as well. So any last thoughts that you want to leave with our viewers, Dr. Miller?
No, I guess the only thing that I would say is if you're having reflux, it doesn't hurt to get it evaluated. I have plenty of patients that I see that after the evaluation, I don't recommend getting a procedure, and that's for very specific reasons. And there's also plenty of patients that I see that didn't know that this was an option, and once they have it, they wish they had had it years ago. And probably the saddest thing I see, those patients that waited so long that the reflux kind of eroded the esophagus to a degree that a surgery or a procedure wasn't safe anymore. So for patients that have reflux, I think, it doesn't hurt to get an evaluation to see why you're refluxing and what the issues are. It can be very, complicated in terms of what's causing your symptoms and what's not. And so getting a thorough evaluation, I think, is really important. And I think a lot of patients can miss some of those diagnoses or kind of miss out on treatments that might be more effective for them just because there's not an awareness of what new options are out there for the treatment of GERD.
Sure. Wonderful. Yeah. And that's a really good point. I think there's GERD and acid reflux is sometimes so trivial. People feel the symptoms and they just go prescribe themselves PPIs over the counter and then they deal with that for years. And to your point, don't wait, get evaluated from a physician and learn what your options are. And that's the whole reason why we do these TIF talks. So patients out there know that there's other options out there. So we really, really appreciate your time, Dr. Miller, and thank you for joining us this evening. You had some really great, your presentation was fantastic. I think it was nice to have the visual aids for people to see how it actually works. So we appreciate that. And thank you again for joining us. And to all those Facebook users that joined us tonight, thank you so much for joining us. We will catch you next Tuesday on our TIF Talk Tuesdays. So thank you, everybody. Stay safe and have a great evening. Thank you.